Good afternoon, everyone, and welcome to our conversation with an MPN specialist. I'm Natalie Giacondo, president of MPN Advocacy and Education International. And for those of you who don't know us, our organization is dedicated to education, advocacy, and support for people living with myeloproliferative neoplasms, as well as their caregivers and healthcare professionals. So we strive to connect patients with the experts in this field, researchers and clinicians, to make sure that they get the resources that they need, that you all need. So today I'm honored to introduce you to today's guest, which is Dr. Kristen Pettit. She is with the University of Michigan, and she's a respected leader in MPN research and in clinical care. And today she's going to talk to us about the various roles that you can find in an NPN healthcare team. So thank you so much for joining us.
Thank you so much, Natalie. Thanks for having me, and thank you for everyone for joining.
All right, I'm going to take myself out and you can go.
Okay, great. I hope you can all see my full slide screen here. It looks like it should be good. Thanks everyone so much for joining. I know I see a few familiar names in the list, which is great. So today I'm going to be talking about a number of different things, but I'm really here for whatever you all want to talk about and whatever I can help with. So I commonly in clinic get questions about the roles of different team members in MPN care. So I thought it might be helpful to take a few minutes to break that down at least a little bit, at least as far as I see it. And then we can talk about more specifics about this topic or about whatever else you might have questions about at the end. So I just have a few quick slides. So for anyone who might be new in their MPN journey, wanted to just give a little bit of a brief introduction to what myeloproliferative neoplasms are. So the three primarily classical MPNs that we talk about are essential thrombocytosis, or ET, polycythemia vera, PV, or myelofibrosis, MF. There are a few other disorders that technically fall under the MPN umbrella as well. Chronic myeloid leukemia, or CML, is sort of its own distinct entity, has a completely different gene abnormality, and is kind of lumped out into its own thing because the treatment is very different at this point. There are a few other uncommon forms of MPN that are also listed over here on the bottom right. I'm not sure if you can see my cursor, but the bottom right over here, called chronic neutrophilic leukemia, chronic eosinophilic leukemia, and then this other entity that's called MPN unclassifiable, basically situations that don't exactly fit into any one of these specific buckets, but that are clearly part of the MPN umbrella. So that's kind of how this spectrum of disorders looks. So what are MPNs in general? So MPNs are this group of related bone marrow disorders. It all starts when one cell somewhere in the bone marrow develops a genetic mutation. Now, these genetic mutations can be in a couple of different genes. The three most common genes to be involved are JAK2, CALR, calreticulin, or MPL, MPL. So JAK2, CALR, or MPL. 90% of people with MPNs will have one of these three genes that we can find a mutation in that's caused their MPN. So these gene mutations are typically not things that people are born with. They're not thought to be things that are directly inherited through families, although there can be a very slight familial link in some families, at least, that is still sort of in the process of being worked out through research. But in general, these are kind of random, spontaneous gene mutations that can happen throughout somebody's life. I wish I could tell you why they happened or what caused them to happen. But as far as we know right now, we haven't identified a very clear smoking gun out there in the field for most people with MPNs. So we're left with kind of shrugging our shoulders and saying, maybe it was kind of luck, or maybe something you were exposed to, something in your environment. It's hard to know for sure. But we do know that once one of these genes develops a mutation in a bone marrow cell, it can start making more copies of itself gradually over time. all three of these mutant genes are sort of part of the bone marrow thermostat apparatus. So whenever any of these mutations happen, the bone marrow thermostat gets sort of stuck in the on position. So rather than being able to turn up and turn down as the body needs more blood cells or has enough blood cells, it kind of gets stuck in the on position. The bone marrow starts to sort of overheat and overwork and make too many blood cells. So for some people, that can be too many platelets. That's what typically happens in ET first. For some people, it can be too many red blood cells, which is the characteristic hallmark feature of polycythemia vera, PV. And for some people, it can be too many white blood cells in any of these MPNs. The other thing that that's being created by the bone marrow, things that are being created by the bone marrow that we can't as easily measure in routine blood work, but are very important to what we're going to be talking about, are pro-inflammatory cytokines. So pro-inflammatory cytokines, these are proteins that are being made by the bone marrow that cause inflammation throughout the body or contribute to inflammation throughout the body. So these can be responsible for a lot of the symptoms that go along with the disorders and a lot of the problems that can happen along with MPNs, as well as the excess blood cells that are being produced. So what are the issues that can result from all of this? Too many blood cells being produced and too many pro-inflammatory cytokines. The first thing is symptoms, which I'm going to talk about on the next slide. Second thing is the risk of thrombosis or blood clots. So we worry about a couple different types of thrombosis or blood clots that can happen. When a blood clot happens in a vein, the most common type is a DVT, a deep vein thrombosis in one leg. What this usually looks like is one leg becoming enlarged, swollen, red, oftentimes tender or painful. I'm not talking about a little bit of puffiness in both of your ankles at the end of the day. That can happen for other reasons and is often a healthy situation or normal situation, or at least not too concerning. But if there's a big asymmetry between the two legs, that can be a sign of a DVT. The reason those DVTs can become important and dangerous is because they can break off from those leg veins and they can travel straight. They have kind of a direct avenue right up to the lung blood vessels. If one of those clots moves to the lungs, it's called a PE or a pulmonary embolism, and that can be a more serious situation. If blood clots form in arteries, we're talking about things generally like heart attacks or strokes. So that's another increased risk with MPNs. When we're looking at the earlier MPNs like ET or polycythemia vera, there's a risk of progression to things like myelofibrosis, where the bone marrow starts to develop more scar tissue. And oftentimes in that situation, the blood counts start to drop too low rather than too high. The spleen starts to become enlarged and symptoms tend to go up at that point as well. And then number 4 here is the least common risk, but sort of the most dreaded risk, which is a risk of movement into something like acute myeloid leukemia or AML, which is a more aggressive disorder, has a completely different set of treatment options. Fortunately, is a pretty rare thing to happen, but not unheard of and something that we always watch for throughout the course of MPNs. So I said I'd come back to that symptom issue. So part of what we're going to talk about with multidisciplinary teams is symptom management. 99% of people with MPNs report some degree of fatigue. That's kind of the hallmark feature that we deal with in clinic and talk about in clinic. Most common thing tends to be the most bothersome symptom that people experience with this group of disorders as well. It's also the hardest thing to treat, I will say, in my experience at least. But if you're feeling fatigue, you're not alone, and that's here at the top of the scale. After fatigue, all the other symptoms are a bit more variable across individuals. So this can include things like depression or anxiety, spleen-related symptoms. If the spleen's starting to get enlarged on the left side of the abdomen underneath the left rib cage, you can feel some abdominal pain, discomfort, fullness, or something that we call early satiety, which is where you fill up really quickly when you eat. Like maybe you used to eat, be able to eat, a big hamburger and fries and feel fine afterwards. But now you take, a few bites of your hamburger and you feel like you're stuffed. That would be early satiety. Weight loss often comes along with that early satiety as well. Concentration issues are common too. Many people describe it as kind of like a brain fog, just not quite firing on all cylinders, not quite as quick as you used to be. Pruritus, which is generalized itching in across the body, all over the skin, without a clear rash. Usually, this is most common in people with polycythemia vera, and often is triggered by water exposure or heat exposure. So people will say they get out of a hot shower, or they can't take a hot shower because they're just itching like crazy afterwards. One thing that's been increasingly recognized over time is sexual dysfunction issues related to MPNs as well. So we know that that's an issue. Night sweats are common. Bone pain can be common as well, as that bone marrow is overactive and expands, doesn't have much room to expand too. It's got the hard outside of the bones on all sides of it. So that increased pressure within the bone marrow itself can cause some discomfort throughout the bones. It's usually in the bones that have the most bone marrow or the most active bone marrow. It tends to be the long bones, like the femurs, the thigh bones, the hip bones, sometimes the rib cage or the breastbone, the sternum. All of those places are very rich sources of bone marrow, and those are the places that we can see bone pain. Not talking about arthritis pain like a sore knee or sore hip or those kinds of things. It's more like a deep achy pain in those bones themselves. And sometimes we can see fevers as a result of those pro-inflammatory cytokines being produced from the bone marrow as well. So as you can see, and as you've probably heard in the past, MPNs are very complicated and multifaceted disorders, and no two people's experience with an MPN is going to be exactly the same. And this is why a multidisciplinary team approach, I think, is so important for many people with MPNs. So multidisciplinary teams are in medicine are a little bit hard to define, but I put this into AI to see what AI would tell us about definition for a multidisciplinary team. So I think they gave us a pretty good definition here. So they say this is a collaborative group, so professionals from various different disciplines that get together and work together towards a common goal. So the team kind of unites, talks about a specific patient to achieve a shared objective, which is usually improving symptoms or health outcomes. And also providing comprehensive care. So the team providing really being able to provide a holistic approach to an individual person from inside out, top down, and making sure that all health issues are addressed and coordinated. So the benefits of a multidisciplinary approach. So I think taking this kind of approach to care provides certainly the highest possible level of care for an individual to improve outcomes. It's very difficult for one individual physician to tackle MPN disorders alone because they're so multifaceted and there can be so many different angles and so many different issues to address as time goes on, and they can change as time goes on as well. So providing the highest level of care usually involves multiple individuals. Second benefit is highest possible quality of life and the best possible symptom control for you on a day-to-day basis going forward. Again, that is something that likely changes as the months and years and decades go by living with an MPN as well. Um, Increased efficiency, I think, is actually the case with multidisciplinary teams too. There is such a thing as having too many cooks in the kitchen, but actually having oftentimes these multidisciplinary approaches early on results in fewer repeated tests down the road, fewer treatment or diagnosis delays, and things like that. So I think that can be helpful. And then very importantly, also improved understanding and satisfaction on the part of the patient and the family dealing with this disease. So when I talk about a multidisciplinary team, who might actually be a part of that team? Usually the quarterback of this team is going to be a hematologist or oncologist, oftentimes a specific MPN focused individual. Other people that are almost always going to be involved in some capacity are going to be pathologists who you may never meet, may never hear see their name or hear from them other than maybe if you read your report really closely, you may see their name. They're often stuck either in the basement or up here. They're on a totally other campus across town from us, but they are some of the most important people in the multidisciplinary care of patients with MPNs. Pathologists are the ones that will be looking at blood samples, bone marrow biopsies, the genetic testing, the molecular testing, and helping us actually make the most correct diagnosis and helping us follow for any signs of progression or transformation or changes in the disease as time goes on. Primary care physicians are critically important as well. Fortunately, these days, many people with MPNs are living long, happy, healthy lives, and we want to make sure that they are on top of their primary care issues as well, so that we can keep control of blood pressure, cholesterol, monitor for diabetes, keep on top of age-appropriate vaccinations, all these kinds of things that are so important as we're looking, many years and decades down the road for your health. Pharmacists are critically important as well. Drug-drug interactions are common when we're talking about different MPN treatments that we are recommending. And side effects can come up, and it's very important to have a pharmacist involved. When I say pharmacist, it can be partially your neighborhood pharmacist at your CVS or wherever you're going that might be dispensing your medications. But it's also often going to be a clinical pharmacist who's sitting in the clinic with your hematologist or oncologist, helping to counsel you about medication options, medication side effects, all those kinds of things. So those people are generally going to be involved for most patients. After this, it gets a little bit more variable. And this is not an all-inclusive list. I'm sure there are folks that I'm leaving out here as well. But number of different other specialties may become involved depending on your particular circumstance. So pulmonologist, if people have had pulmonary emboli, that's common to have a pulmonologist on board. Or there can be some lung-related side effects from some of the medications we use or infections or things like that. So having a pulmonologist on board is often helpful. Dermatologists can help us oftentimes with that pruritus, that itching that's happening. There are some treatments that the hematologist will be involved in, but some that the dermatologists alone can do. For example, like certain types of light therapy, the UV therapy to the skin that can sometimes help in certain situations. Sometimes surgeons, usually not directly related to the MPN, but heaven forbid you need a surgery for some other reason. Let's say you need an orthopedic surgery, a hip replacement or a knee replacement down the road. Surgeons and hematologists will absolutely work together to make sure that that's being done as safely as possible in a situation with an MPN. Neurologists, heaven forbid if there's a stroke situation. Dietitians, cardiologists, gastroenterologists, rarely radiation oncologists if the spleen is very large. Occasionally we'll give baby doses of radiation to the spleen to help shrink it down, at least temporarily. I think psychiatry and psychology is something that's underutilized and sometimes difficult to get into these days, but critically important in managing MPN-related symptoms long-term. Physical therapy can be helpful in some situations, social work in many situations to help with the kind of holistic approach to the patient and the family and making sure you have all the support that you need and can get. Palliative care and symptom management. Palliative care, oftentimes when I bring this up in clinic, sounds like a scary word. I'm not talking about hospice care when I'm talking about palliative care. Palliative care is a group of symptom management specialists, really. So they can be used at any point in somebody's disorder. They can be helpful in helping to manage some of these difficult to treat symptoms if the hematologist needs help with them, if the patient needs help with them. And then bone marrow transplant team for situations where more aggressive treatment is warranted. So all of this seems overwhelming, kind of managing all of these different people. I don't think anybody has all of these different specialists involved in their care necessarily, but it's often going to be kind of a smattering of perhaps a couple of these different people that will be useful for your individual situation. I wanted to take a minute also to talk about the role of advanced practice providers or APPs. You may or may not have heard that term, but when I say APP, talking about a couple of specific people, nurse practitioners or physician assistants primarily. Advanced practice providers are becoming more and more common in subspecialty care, like MPN care, and across the board, your cardiologist might have an APP that works with them. Your primary care might. It might be a number of different areas. This is becoming more and more common, especially as there are more and more physician shortages across the country. APPs are extensively trained in an individual specialty. So nurse practitioners usually go through a nursing avenue. They're generally registered nurses first, and then go on to more specific PhD level training, really, to earn their nurse practitioner degree, and then really focusing on an individual disease subtype, or sometimes a more diverse primary care specialty. Physician assistants similarly go through a curriculum very similar to medical school, but just a little bit abbreviated, a little shorter, and then go on to specialize in an individual specialty. So nurse practitioners or PAs may be available to help you through your hematologist or oncologist, or through various other subspecialties. They can play a role in your team in a number of different ways. They may be the actual person who you're seeing face to face in the clinic at times. They may be performing your physical exams. They may be prescribing oftentimes your medications. They may be performing procedures like bone marrow biopsies, for example. Here at the University of Michigan, our physician assistants perform really all of our bone marrow biopsies. I tell people that you don't want me to do your bone marrow biopsy. I haven't done one in a lot of years, but my physician assistant who works alongside me is fantastic. And if I needed to have a bone marrow biopsy done, she would absolutely be the one doing it. So these people are really specialized in really focused areas, and might be a very integral part of your team. Essentially, they can generally do everything that the MD would do, but work usually alongside an MD. So with all of this, how do you navigate multidisciplinary care teams? I think the first thing that I want to say, that I always say in these sorts of talks, is that I highly recommend having an MPN specialist involved in your team. General hematologists and oncologists out there in general practice oftentimes might see a handful of patients with MPNs in their whole career. These are not very common disorders, and they may feel very comfortable treating them, or they may not. The research has come a long way in the past decade, especially in MPNs. Things have changed, so I think it's helpful to have a specialist involved who does this all day, every day. It's also helpful as new treatments are coming through the pipeline as well. The research is moving fast, and having access to an MPN specialist will mean having access to the most up-to-date treatment options if it's appropriate for your situation. How the MPN specialist is involved can vary. This can be someone who becomes your primary hematologist and oncologist, or it might be somebody who you check in with once a year, or even every other year if things are going well, just to make sure you're still on the right track. For most cases, your hematologist or oncologist is going to be kind of your quarterback for the situation, and is going to be really the one that is not exactly calling the shots in all different areas, but really helping coordinate all of the care, and making sure that that everything is done with the MPN specifically in mind. There's a couple different ways that this can work. It can be helpful to stick with one health system for the majority of your subspecialty care, especially if you're needing to see multiple of these different specialists. Having everything under one roof can be really helpful as far as communication and coordination among the team. If all of your subspecialists are in one health system, then it's very easy for the different physicians or APPs to or pharmacists or whoever else is involved to be emailing each other, reaching out through the electronic medical record through our portal, and to be talking to each other back and forth about your situation on a regular basis. It's a little bit tougher if things are in multiple different health systems. But the other way that this works well is if you're not close to an MPN specialist at a specialty center like a university and academic center, then going through your local health system may be very appropriate as well. So how this can work is seeing an MPN specialist periodically, even virtually. I should have mentioned that as well. Many of us can see patients virtually if you don't have easy physical access to one of us. And then we can coordinate with your local hematologist, who would then really be your quarterback with all of the different subspecialties that were closer to home for you. I think the way that this gets tricky is if you happen to have subspecialists in multiple different health systems, then it gets a little bit tricky. I think keeping everything under one roof can be helpful if it's possible. And the last thing I would say is speak up. Use the portal, use the phone, however you need to ask for referrals or more communication if you feel like your symptoms or your issues are not being well addressed, and not well controlled, or if your MPN isn't being taken into account when talking about some of the other issues that might be going on. So yeah, so those are the end of my slides. I just had those few slides that I wanted to go over, and then I would love to spend most of the time talking about any questions or concerns or anything else that I can help with.
Thank you so much for that. As you were talking, I was just wondering about, this is a huge team of people that has to be managed. And I'm just wondering people's experience of managing all of those different members of their healthcare team. For example, you talked about the pharmacist, a clinical pharmacist. I have never been in touch with a clinical pharmacist before, but perhaps this is something that people with MPNs experience more frequently. Do you find that do you have any idea about that? Are people talking to their clinical pharmacists?
At academic centers, at some of the big MPN centers, absolutely. So our clinical pharmacists speak to essentially all of our patients who are going to be starting a new medication, either in person or on the phone. They do sit right here with us in the clinic, right next to us. So they help us make decisions about which treatment is best. Fortunately for MPNs, we've got multiple different treatment options for different situations these days. So we do rely heavily on the clinical pharmacist when we're having this conversation, to look at drug-drug interactions, look at, what might be best for the patient given other ongoing health issues or whatever else. And then often they will help actually counsel the patients on what to watch for here at our center. If they're not available to sit down face to face with somebody right there, right then at that moment, then it's often a phone call afterwards. So yeah, this does happen, at least I think at the MPN centers in general,
Gotcha.
or should be happening.
Gotcha. Okay, well, that brings us to some of our questions here. Um, so this question is an interesting one. How do we know if a hematologist oncologist is an MPN specialist?
Yeah, it's an excellent question. There is no like certificate or badge or something that you get that says MPN specialist. So it can be hard to tell. It's really kind of a self-designated thing. So I would certainly ask your hematologist. If they feel like MPNs is one of their specialties. Another question to ask, another way to get at that is, what other disorders do you typically treat? If they're saying, I treat breast cancer, prostate cancer, leukemia, MPNs, all these different things, then it's a little bit harder to expect that they're going to be truly a specialist in one area and up to date on things.
Right.
Oftentimes MPN specialists, though, because MPNs are so rare, depending on geographically where someone's located, it's pretty common for MPN specialists to also focus on some other very related disorders like myelodysplastic syndrome, MDS, or acute myeloid leukemia, AML. All of these like overlap a lot. So many places you will see that an MPN specialist is seeing a few different disorders. But I think those are some ways to kind of get at that question. Also asking them, I think another key way to get at that answer is to ask them what research they're involved in with MPNs, or if you feel uncomfortable kind of directing a question right at them like that, you can ask kind of at your center what research is going on involving MPNs, or is there any research that I should be considering about MPNs? And their answers to that question should kind of give you an idea of whether or not they're a specialist. If they say, yes, we have a whole bunch of clinical trials going on here that I'm leading, then that's pretty obvious. If they say, no, we don't really do research in that area here, then it might be worth seeking out somewhere else. There are also lists of places. I know the MPN advocacy and a number of other places, a number of other organizations kind of keep lists of recommended MPN specialists or centers to consider too. So you can always reach out there too. I hope that's okay to say, Natalie.
Oh, absolutely. And also, we get a lot of emails and phone calls directly asking, do you know an MPN specialist in my area? Is my physician an MPN specialist? And so we can also help to make that connection. And you can look at our YouTube channel, and if you just look through all the conversations with MPN specialists, certainly any of those physicians and researchers are indeed specialists. So, okay, so if you can only see an MPN specialist infrequently due to insurance or geography, or not at all, can you talk to how to ensure we are getting good care with a regular hematologist, oncologist? I'm in transition to this type of model due to insurance limitations, battles, and not happy to rely on someone that isn't a real expert in MPNs.
Yeah, good question. This does happen. I'm sorry you're dealing with that, whoever asked the question, but it certainly does happen. There's a couple different things I want to say about that. So, one is that if it's geography that's the issue, like for example, here in Michigan, the Upper Peninsula is not close and it's pretty remote and difficult to get around, especially in the winter time, but really anytime. So, many places will offer things like virtual visits. Fortunately, I don't know if you're up to date on what's going on in the world as far as medical payments and things like that. I'm not making any political statements at all here, but we don't know what's happening with virtual visits going
Okay.
forward for the long run, whether this is something that things like Medicare will continue to cover or not. As of right now, we have not run into issues with it, at least here at the University of Michigan, but this could change over time. But saying that with that caveat, virtual visits are an excellent way to get access to experts if you don't have easy physical means to get to their center. Most places you do need to be within the state to have a virtual visit because of the way medical licenses work. They're state by state basis, which don't get me started. It's kind of silly, but it is the way it works. So there are a few places, for example, Cleveland Clinic, that have sort of gotten around that in some ways and will do like an ask the expert kind of opinion without being a formal medical visit for you specifically. But if you do have a center in your state, at least, you can oftentimes get access through a virtual visit. If insurance is the limitation, though, that doesn't necessarily help. So in that situation, or if you don't want to see an MPN specialist regularly for whatever reason, I think keeping yourself as well informed as possible is really important. Whoever's asking that, I love that you're on this right now because it means that you're doing that. So I think this route, the MPN advocacy group, a number of other groups that are out there online, watching these videos, staying up to date on the research that's going on that's being presented through these videos, I think is fantastic for you to be able to be your own advocate. Um, your hematologist and oncologist may have a variable different level of comfort with your situation. So staying up to date on these videos, and then you can, this happens often, I think, that you can actually go to them and say, hey, I heard about this new medication that I heard just got approved. Is this something that's an option for me? And they may say, oh, I don't know much about that. Let me go look into it. And oftentimes they will also have an avenue to the specialist. Even you, if you don't have a direct avenue to them, oftentimes your hematologist and oncologist will have a go-to person that they will reach out to find out more if they need to. So I definitely say be your own advocate. Continue to stay involved as much as you can to stay on top of what's going on, and yeah, advocate for yourself if new symptoms or issues come up.
Yeah, I wonder if there are some, I know there are some MPN specialists who are willing to consult with local hematologists, if your doctor is not a specialist. Do you recommend people bringing that up in their conversations with their hematologist, or is that something that, is offensive? Or, I mean, I guess you can't worry about that, but
Yeah, you can't worry about that. And if any physicians are offended about that, then they might not be the correct person for your care. I think it's a very fair question to ask. Is this something you could consult with someone else on, or should I see someone else about this? Those are very, very fair questions. Even as an MPN specialist, I commonly recommend that for folks also. If people if there are situations where we're in a rough spot, there are multiple different options, or there are a few different options, then oftentimes I will reach out to colleagues and kind of poll the audience and see if other people have other bright ideas, or even, recommend or suggest that a patient go get another idea from another physician too, if they want to, in the MPN community. So yeah, we in medicine, we should all absolutely be humble and be able to take other people's opinions, because they're so important when we're dealing with these disorders where there's often no right or wrong answer. So I would say don't be shy, speak up. We're used to being asked those questions. This will not be the first time that they're asked that question, probably that day even. So don't be shy.
Perfect. See that? Okay, so advocate for yourselves, tell your doctor, ask for that consultation, see what they know. Okay, so I know that bone marrow, this is another question. I know that bone marrow biopsy is the standard procedure, but how does it change the treatment if your doctor says you are stable and doing well on current treatment of HU? Are the blood tests not able to pick up any changes? Thank you. I admittedly have not done a BMB and my hematologist is not pushing for it.
Yeah, so great question about bone marrow biopsies. So sometimes they're critical and sometimes they're not. So technically, to make a diagnosis of most of these MPNs in most situations, to check off all of our check boxes according to the World Health Organization criteria for diagnosing these disorders, usually a bone marrow biopsy is one of the check boxes to tick off. That being said, we don't necessarily always recommend it. It's an invasive procedure. It's very safe. It shouldn't be very painful. It's sometimes a little uncomfortable, but very briefly. So there's not a ton of reasons why not to do it necessarily, but it may not be 100% necessary for every situation. If we see, elevated red blood cell numbers, elevated hemoglobin and hematocrit, and we find a JAK2 mutation and the hormone called EPO in the blood is low, then we're pretty positive this is a polycythemia vera diagnosis. There can be some benefits even in that situation to doing a bone marrow biopsy. For example, the only way to pick up like very early myelofibrosis, the very early scar tissue in the bone marrow, is to look at a bone marrow biopsy. But oftentimes that wouldn't necessarily change the situation, change the management. So we usually recommend bone marrow biopsies, at least at the baseline at the time of diagnosis, but not always. So if your doctor's not pushing for it, I mean, you can certainly ask them about it, but it may not be necessary for you. Down the road, as far as how we follow these disorders like ET and PV and myelofibrosis, all of them really down the road, primarily it is by blood counts and by physical exam, feeling for any signs of spleen or liver enlargement, and by taking your history, talking to you, seeing how you're feeling, what new symptoms are there, those kinds of things. So usually we don't need repeated bone marrow biopsies down the road to see how things are going. Usually we can tell by the blood counts and all of those other things. If there are signs of the disease progressing into myelofibrosis or something else or causing more problems, then oftentimes we will take a look in the bone marrow or do more detailed genetic sequencing to look for new gene mutations, which we can do from the blood. That part is actually pretty easy these days. So oftentimes that we will be kind of driven by the blood counts and by your symptoms or exam to take that next step and do those other things. But that's not the only way that things can change down the road. If people have ET or PV, even if the blood counts are relatively stable, symptoms can change over time too. People can develop new side effects to medications. The disease can cause more symptoms or just a shift in symptoms as time goes on. And sometimes treatment needs to change because of those things. And it's not necessarily a progression of the disease. It's just a change in the way your body's experiencing the disease over time. So it may or may not, depending on the blood counts, that may or may not warrant further workup like bone marrow biopsy and exam. But if you are feeling much differently, much different, it may be worthwhile to consider a different change in treatment, even if everything else looks stable. Did that answer the question?
I think so. I think so. All right, I'm going to go to our next question. How do I find how do I find a PCP for my PV? He admits little knowledge, yet wants to take control of the referrals.
Uh-huh. Yeah, so I'm great to hear that your primary care is involved and wants to take control of things. I do think that having a hematologist is important. So if your primary care doctor right now is the one that's mainly managing things and calling the shots, I think you should also have a hematologist or oncologist involved. There are many primary care doctors who are absolutely fantastic at managing a lot of different things, but there are some aspects related to MPNs that primary care doctors, generally speaking, are usually not comfortable with. For example, if you need therapeutic phlebotomies over time, the periodic red blood cell removals, that's something that would usually have to be done by an infusion center that's usually under hematology or oncology guidance. If you needed a more specialty medication, like hydroxyurea, like an interferon medication, like something along those lines, then certainly a hematologist or oncologist should probably be the one managing those things. So I think it's great if your primary care doctor wants to be a quarterback, if it wants to take that quarterback position. That I think that is great if you feel comfortable with them and they're involved. But I think a hematologist oncologist should definitely still be part of your care. And ideally an MPN specialist involved in there if you can.
Yeah, anybody who has additional questions about finding an MPN specialist, please do email us directly. You can email me at ngiacondo@mpnadvocacy.com, and we can have an ongoing conversation about how to find those people and even sort of work around some of these issues that are being brought up. For example, this next one, which is the person who had spoken to us earlier about finding an MPN specialist, how do you know if it was a specialist, is now saying too that, insurance may not be covered, may not cover that specialist. So, that is an issue. And I know that as we move into this sort of uncertain time in healthcare and in insurance coverage, we don't know how those things are going to go, but we do know that there's help out there. So if you contact us, we can put you in touch with the right people. So please do use us as a resource. Um, Also, someone said go to MediFind to find specialists. I have never done MediFind, but that might be a potential avenue as well. Okay, should we retain care with a hematologist, oncologist in coordination with the MPN specialist then? I'm struggling to understand whose care I should stay with. I was referred to Michigan Medicine because my HO believes a BMT is the only known cure.
Yeah, so a couple things there, I think. So it can go in. I usually tell people I'm happy to be involved, or as involved or uninvolved as you want me to be in your care. So it really depends on your situation. Sometimes if your MPN is not causing a whole lot, fortunately, of problems, if things are going pretty well, if you're comfortable with your local care, and especially if you're a ways away from us, then usually how we're involved is by kind of periodic check-ins once a year, once every 6 months, however often is usually warranted, to make sure that we'll request all your records over the last year in advance, look over the notes, look over your blood counts, see how everything's been going, and then once a year basically kind of sit down and talk about where we're at, if there's any new research or treatments you should be considering, or if we're in good shape, and just carry on. So that's oftentimes what we'll do. And then in that case, the hematologist closer to home is usually the one kind of running the show on the day-to-day basis. And you can always, if heaven forbid, if anything changes, them or you could always reach out to the specialist. In the meantime, you're already established. It's easy to kind of get you slotted back in to see how things are going sooner. So that's one common model. The other way is that, especially if things are evolving, if we've had to try multiple different treatments, if you're more symptomatic, if you're kind of struggling with your disease, to be frank, more, and or if you're closer to an MPN center, then it may make sense to keep your basically primary hematology care under the MPN specialist at the usually academic center. In which case we would be the ones, for example, monitoring all the blood counts, making any medication dose adjustments, all those things on a day-to-day basis. So I think either of those two situations are fine. With with being under the direct care of the MPN specialist as the only person or main person, usually you do have to be seen, physically in person periodically to be able to measure your spleen and things like that. So just one thing to keep in mind. As far as I wanted to mention the bone marrow transplant thing too, if that's okay.
Yeah, of course.
So it's a good question. Thanks for bringing up bone marrow transplants. Bone marrow transplants for MPNs, your doctor's correct. It's the only possible cure for MPNs that we know of so far, at least. Oftentimes the cure is worse than the disease. Sometimes that's true, sometimes that's not. The process of a bone marrow transplant is pretty major, though. It's certainly life-changing, especially for the first year after the transplant. So it's not something that anyone would take lightly, of course. So it's a big decision. We typically generally out there, bone marrow transplants are usually not recommended for situations like PV or ET because what I already mentioned, the cure is generally worse than the disease, and we usually have other options of ways that we can manage things without exposing you to those risks. But when we're dealing with myelofibrosis, not all myelofibrosis, but myelofibrosis that's on the higher end of the risk spectrum that we have, that's where we do start talking more about the bone marrow transplant option. So if that is the situation for you, then I think the next best step is absolutely being evaluated at a transplant center. Their first step is usually to just give you information and get information from you. So to find out more about your health status, your symptoms, how fit you are, all of that to even see if you'd be potentially a candidate for a transplant. And then also for you to find out about the process to see if it's something you would be interested in taking on. If it seems like both of those things line up, that you're interested and that your health status is such that we think we could get you through it, then they would take the next steps at starting to look at who a donor would be, doing more specific health organ testing, things like that, and then kind of going from there. Bone marrow transplant centers are definitely specialty centers. For example, there are 3 in the state of Michigan, and they're spread across the country, so they're not necessarily right in your backyard, which can be one limitation. But yeah, an informational meeting would be the first way to go if that's something you want to consider.
Perfect. Thank you. That's okay. So what type of liver issues does hydroxyurea cause?
Good question. Not many. Actually, hydroxyurea typically is pretty safe as far as the liver goes. We can occasionally see, especially at high doses of hydria, we can see some tick up in the liver function tests. We don't usually think of hydroxyurea causing significant liver damage or injury. We do in people who have other coexisting liver disease for other reasons, we generally will avoid high doses of hydroxyurea if we can to avoid making the situation worse. But usually we're not seeing any major issues related to the liver and hydroxyurea.
Okay, so if you're having a liver issue and you're taking this medication, you may want to investigate further.
Absolutely. I would investigate further before. I wouldn't necessarily just chalk it up to the hydroxyurea because it would be pretty rare for that to cause anything other than just a tiny little bump in the numbers on the blood counts.
Okay. All right. What's the best way to talk with clinicians who don't know much about our disease or aren't familiar with it, especially when in an emergency or urgent situation or in interpreting blood-based test results? Thank you.
Yeah, absolutely. Yeah. So, yeah, this is especially important when talking about emergency situations, like heaven forbid if you're in a car accident and you're in the emergency room and they're saying you need a surgery or something like that. This is important. So, it depends on your situation. There's not a one size fits all answer to this necessarily. For ET and PV, for most people, what we're worrying about most in an emergency situation is a blood clot. So that is generally what we want people to know about. For myelofibrosis, it's a little bit different. It can be the enlarged spleen, it can be low blood cell counts, that's your baseline, and you may need a transfusion. Whatever your specific situation is. The what I usually recommend for my patients when they ask about this is to put it in your cell phone if you have a smartphone, which most people do these days. There's an emergency emergency contact section or medical information section that emergency responders, first responders are used to going there. If heaven forbid, if you are not able to communicate what's going on with you, that's usually the first place they'll look, is in the emergency ID in your phone. So they can get access to that. They don't need you for that. That's something that's available for anybody who has your phone. And you can put in there your medications, your diagnosis. You can put a little narrative too, like you can say, polycythemia vera, risk of blood clots, on aspirin and hydroxyurea or something like that. And so that they'll have access to it. You can even put your doctor's information in there as well. And of course, your other emergency contacts. So that's what I recommend to people. You can also put it like a card in your wallet that says similar
Right.
information. Both of those are good places. I do think emergency responders these days usually look at the cell phones first.
Good point. And that's a great idea. And actually, we have a blood card that we pass out at our in-person events, and we can also send those in the mail. So if anybody wants one of those cards, please again contact us. But yeah, that's a really good idea to put it in your cell phone. I didn't know there was a narrative section, so that's a really good point. We just have time for a couple more questions. If you sent in a question and it did not receive a response today, I am going to write these all down and I will try to email your responses personally to you. So I apologize if we didn't get to it. We'll take about 5 more questions and then we're going to move to hear from our industry partners. I hope that you'll stay with us to hear that because, our industry partners, the conversations that we have between physicians, researchers, patients, and industry are so vital in the progress that we've made in terms of moving towards a cure for this disease. So, anyway, here's our next 5 questions, and then we'll move to that. So, this is a parent of a 23-year-old living in one state, and she's in another state. She's learning how to navigate the healthcare system where she is. Do you feel that beyond primary care, who does her yearly blood work, she needs to incorporate a cardiologist, a nephrologist? I'm trying to ensure that she can remain healthy for as long as possible, and I know that these are areas of concern. I feel like the MPN specialist looks at a very small set of labs and sends her on her way. And what is your thought on integrative medicine doctor who is looking more at the body systems? It's a long question.
Yeah, so good questions. I wish our healthcare systems anywhere were easier to navigate. It's a problem for whether you're 23, whether you're 80, anywhere in between, it's a problem. But yeah, it depends on the situation, really. This is my answer to everything, I know. I'm sorry. But for sure, having a hematologist, oncologist, and a primary care doctor are the most important things. She may not need other specialists. So when I show the long list of possible specialists, it's not necessary for everybody. If blood, oh, I'm sorry, we've got a fire drill or something going on
Oh,
here. Sorry if there's there's
we
beeping.
don't hear it. We don't hear it. But if
Okay,
you
good,
have to
good.
leave because of an
No,
emergency, please do.
I don't. We have a drill
Okay.
like every other day around here. But
Okay.
so you may not need she may not need additional specialists on board. But as long as you're comfortable with her hematology and oncology care and with her primary care, the hematologist oncologist, it typically is a pretty small set of blood work, small set of labs that we're looking at. For most people, we're looking at the CBC and differential every time they get blood work back and every time they get it drawn. Oftentimes, we're also looking at metabolic panel and enzymes like LDH for an idea what's going on with the blood work, with the bone marrow, but not necessarily done every time. So it's probably appropriate if she's doing well to have just a small panel done each time. And as long as our primary care doctor is up to date on all of the other routine things, which there probably is not much else for an otherwise healthy, hopefully 23-year-old, then that's probably all she needs, unless other issues are coming up with her symptoms or anything else related to the disorder. What was the other part of the question? I'm sorry. Oh, integrative medicine thing. Yeah, it's kind of variable, to be honest with you. It never hurts to look into those sorts of things. I would just be very cautious. What I would say is be very cautious about anyone trying to sell you things. If you have an appointment with with any sort of medical practitioner that then walks you into a room full of different things with price tags on them, I would just approach that situation with a big side of caution.
Good point. Very good. Okay, so this is the next question. I have progressed to myelofibrosis from ET after 6 years of interferon. MD Anderson put me on hydroxyurea. My pain is worse, but my quality of life is better because I'm not sick in bed weekly. My MPN specialist has been trying to get me to try Jakafi, and I'm scared to death of it. My stomach is already extremely sensitive, and I'm concerned about shingles. Can I get your thoughts on Jakafi side effects that you commonly see in patients with stomach problems?
Yeah. So Jakafi or ruxolitinib is the JAK inhibitor that's been around the longest for myelofibrosis or for PV are the two indications for Jakafi. So pretty common medication, and we've had it out there for quite some time now. We have long-term safety follow-up with it. It does tend to be a relatively safe medication, and the whole goal with the medication is for people to feel better, not worse. So that's absolutely the goal of having you on that would be to improve quality of life even more and improve your symptoms even more. So if it didn't do that, first of all, then that would be a reason to potentially switch to something else. As far as stomach side effects, Jakafi tends to be pretty gentle on the stomach, and everybody's different, of course. But especially at low doses, most people don't tend to have many issues with the Jakafi on the stomach. If it's going to happen, it tends to happen in the first week or two that people can feel either a little nausea, a little diarrhea, or a little, bloating or gurgly. But it's usually pretty mild and pretty short-lived. And we have supportive medications. You could certainly ask for things like nausea medications and make sure you had Imodium or things like that on hand before you started it. But and to make sure that you started at a low dose and then gradually ramp up. That's another strategy that can certainly help. But I wouldn't expect it to cause major problems, although everyone's different. As far as the shingles issue, that can be an issue over time as people are on medications like Jakafi or any of the JAK inhibitors over many years. They can suppress a certain type of T cell in your body, so they're basically mildly immune suppressive medications. In the short term, that likely doesn't mean very much for people's health, but when people are on them for many years, that risk does kind of build up. So risks of certain infections, some atypical infections like shingles can definitely happen, and skin cancer risks like basal cell or squamous cell can go along with that as well. So I do think it's important to make sure you're up to date on vaccinations like shingles vaccine if you can. If you can't get shingles vaccine, then some people will choose to take medications like acyclovir preventatively to make sure that doesn't happen instead. The other things like skin cancer risk, important to have I think for most people on Jakafi, if not everybody on Jakafi, you should probably have a dermatologist and have a skin check periodically to make sure that any things like squamous cell or basal cells are picked up early and taken care of.
Very good. Thank you for that thorough answer. This was lovely. Thank you so much for all of your time today. And I know that everybody here thanks you as well. Lots of gratitude. And you're welcome to stay on with us, or if you need to get going, you could do that. We've got about 5 more minutes where our industry partners are just going to share some of their updates. So either way, we hope that we'll see you again. I'm sure that we will, and we really appreciate your insights and your expertise today. So we appreciate that. Thank you so much.
Thank you so much, Natalie, and thanks for everybody for all the great questions.
Very good questions. And again, if your question was not answered, I plan on emailing you. And please do contact us directly whenever you need someone or something. We will try to help you with what you need. So right now, hopefully you will stay on with us while we listen to our industry partners, give some updates about things that are important to you that you might need to know. We'll start today with, oh, we're still seeing your screen there. Let me just... There we go. Perfect. If Martin Blood is here with us from Farm Essentia, and he is going to give us an update. Hello, Martin. Of
Hello, Natalie. Thanks for having me here.
course.
Again, my name is Martin Blood. I work for Pharma Essentia. This is a international company based out of Taiwan and having a U.S. Corporate offices are in Burlington, Massachusetts. Our flagship product, for some of you who may already know this, is Besrimi. It's a pegylated interferon currently indicated for treatment of patients with PV. An update for everyone is that as of this week, we have filed with the FDA for an indication in ET. So hopefully within the next 6 to 12 months, we should hear some information from the FDA on potential approval for that indication. Outside of that, we do have activity in terms of research going on in the myelofibrosis space also with a trial called HOPE PV. And that particular trial is looking at, it's HOPE PMF. And that particular trial is looking at pre-fibrotic myelofibrosis patients. So be looking out for that in the near future is opening up in several of the institutions across the country. Outside of that areas, you can go to our website at pharmaessentia.com, and we do have many patient activities on there in terms of information about PV, information about reimbursement programs, and help for patients to get our drugs if there is an appropriate treatment for you based on what your physician does.
Thank you so much, Martin. We appreciate that
Thank
update.
you.
Next, we'll hear from Kimberly Price with Cartos Therapeutics. Kimberly?
Hi, Natalie. Thank you so much for this amazing webinar, and thank you to Dr. Pettit as well and all the patients who are listening and the caregivers. So my name is Kimberly Price. I work for Cartos Therapeutics, and it's an American company based out of San Francisco Bay Area, and we have a medicine in development called navtemadlin for myelofibrosis. And navtemadlin belongs to a class of drugs called MDM2 inhibitors. And so how that works is that our bodies have a natural tumor suppressing pathway controlled by a protein called p53. In healthy cells, p53 helps detect problems that can stop abnormal cells from growing. Now, in myelofibrosis, this pathway is often turned off because another protein called MDM2 blocks p53. And when that happens, abnormal cells multiply unchecked. So navtemadlin is designed to block MDM2, which allows p53 to turn back on. By restoring that pathway, navtemadlin can help eliminate myelofibrosis cells. Now, Cartos has a phase 3 registrational trial enrolling patients with myelofibrosis whose disease has a suboptimal response to the treatment of a JAK inhibitor called ruxolitinib. Now, suboptimal response means that following treatment of ruxolitinib means that the spleen remains enlarged and symptoms persist. So there are no currently approved therapies in this setting right now. And so this study is called POIESIS. I don't know if you can see on my screen. This is how you spell it, POIESIS. And we have a website that you can look at. It's called POIESIS Trial to see if you're eligible or if you're interested in learning more. It's a global study with over 250 sites around the world and over 70 centers in the US. I mean, patients have to have primary MF, post-ET MF, or post-PV MF and never had seen Jakafi or ruxolitinib or JAK inhibitor. There are other criteria that you can discuss with your physician, advocacy group, or go to our website to learn more. Thank you again. I really appreciate the time today.
Thank you, Kimberly. So next we'll hear from Joe Lors at Silence Therapeutics. Joe? Oh, there you are.
I got you.
There you are. Okay.
All right, thank you. Give me just one more second here. Sorry, oh well, I'm gonna wing it here. Anyways, Joe Loris, I'm the senior director with Silence Therapeutics. We're based out of London. We have research scientists in Berlin, Germany, and also we have an office in Hoboken, New Jersey. We've been around since 2005, and we are glad to be a very diverse company. Our product, Diverseran, is an siRNA drug used for polycythemia vera. It's an investigational drug, and it is being investigated in a phase 2 study currently, which we just fully enrolled, and we're looking for a data readout in the third quarter of 2026. The Dipersuran is a sRNA drug that targets the TMPRSS6, and it helps increase your own natural hepcidin to help with reducing blood clots, reducing thrombotomies, reducing symptoms that PV patients have. And it's a very good drug investigationally, and we'll be starting the phase 3 study shortly after the readout comes out from the phase 2 data. So we're excited to announce that that phase 2 is closed now, and that we're going to be looking for sites here in the US and worldwide for phase 3 coming up next year. And just want to thank everybody for joining this program. We love Dr. Kristen Pettit and Natalie. You guys are doing a great job. So thank you very much. We'll talk to you soon.
Hey, thanks so much, Joe. And last but not least, we will be hearing from, a moment. We'll be hearing from Seema Bhatt. Seema, are you here with us?
Yep, I'm here. Thanks so much. I echo everyone's thoughts. Thanks so much for hosting such a great webinar and allowing us to come talk about our clinical trial. So my name is Seema Bhatt. I am an executive medical director at Disc Medicine, and on behalf of the Disc Medicine team, we'd like to introduce the Rally MF clinical trial. It is a phase 2 trial, and it's open to eligible patients with primary or secondary myelofibrosis who either have anemia, and that's defined as a hemoglobin less than 10 grams per deciliter, or are requiring transfusions. Patients may be enrolled regardless of whether they're on MF-directed therapies like JAK inhibitors or not. DISC-0974 is an investigational monoclonal antibody, and DISC is studying the potential to reduce hepcidin, a protein that's abnormally high in patients with inflammatory conditions, including myelofibrosis. The goal of the study is to understand if treatment with DISC-0974 can improve anemia and reduce transfusions. The study will also be collecting information regarding safety of DISC-0974 and any side effects or risks to better understand how improvement in anemia may also improve the way patients with myelofibrosis feel and function. The drug is administered subcutaneously as an injection once a month for 6 doses, and patients who do have a benefit with their anemia improving may continue the investigational drug for a longer period of time. The trial is now enrolling at many sites across the country, and if you're interested, please do feel free to reach out for more information. You can find us on our Disc Medicine website or on clinicaltrials.gov. Thank you so much.
Thank you. And thank you to all of our industry partners for sharing today. And also, once again, to Dr. Pettit. We are so happy to be able to host a series like this, and we hope that you will join us again next week when we have Dr. Linda Razar from Johns Hopkins University talking about MPN progression. That will be on November 11th. And then we have Dr. Angela Fleischman from UC Irvine, who will be discussing inflammation and the Mediterranean diet on November 18th. You can find registration details in your email. Also, there will be additional resources on our website at www.mpnadvocacy.com. On behalf of myself and the team here, we thank you again for spending your time with us, and we hope that you have a wonderful rest of your day.